Welcome to the March School Health Learning Collaborative. Today, we are going to talk about rashes, and this is an exciting subject for, I know, all of you school nurses because it's something that you see every day, and they're common, and there are all kinds of rashes, and so I'm excited to share this learning collaborative with you. A little bit about our presenter. Dr. Nicole Harder is a board certified dermatologist and pediatric dermatologist. She completed her dermatology residency at the University of Southern California and pediatric dermatology fellowship at Lurie Children's Hospital, Northwestern Medical Center. Dr. Harder currently lives in Omaha, Nebraska, where she serves on the faculty as Associate Professor of Dermatology at the University of Nebraska Medical Center. And Dr. Harder is the Chief of Pediatric Dermatology at Children's Nebraska and Pediatric Dermatology Fellowship Program Director. Her practice focuses on complex medical dermatology, inflammatory skin disease, laser therapy, and dermatologic surgery. So lots of good things from Dr. Harder today. Please remember, I just wanted to remind everybody that you will be sent out the CNE certificate, how to get access your CNE certificates after tomorrow, probably. So you won't get them to your email right away. It'll be coming from us tomorrow, hopefully tomorrow. And you also have to be on the video today for at least 45 minutes in order to get those CEUs. So just a reminder that I forget to say sometimes when we start, but with that, I'm going to hand it over to Dr. Harder.
Great. Okay. Thank you so much for the nice introduction. Can everyone hear me okay?
You sound good to me.
Okay. I'm going to share my presentation. Let me get it up and rolling. Just make sure. Okay. Can you see the slide that says pediatric dermatology?
Yes, we can.
Excellent. Okay. So I won't be monitoring the chat. I think we have some team members that will be. So as questions pop up, please feel free to write them in and we can address them as we go. Or I'll make sure we have time for Q&A at the end. Definitely meant to be informal, educational, and just provide some insight on things that you're definitely seeing. Maybe things you see less of, but then, when do we act? When do we worry? So some objectives to identify common pediatric dermatologic conditions and really know when to worry about a rash or when to wait on an evaluation or a referral. And with the hope of increasing confidence in making these recommendations to families and their caregivers about what they need to do for further evaluation and treatment. And our goals are kind of, what is benign, what is contagious, and what's actually worrisome versus kind of what's simply frustrating, which some skin diseases really are. We're going to briefly categorize skin disease. This is kind of how I've broken down the presentation, and we will not get through all of the things in all of these categories, but just some heavy hitters. So we have primary cutaneous infections. These are things that are infections on the skin. We have a cutaneous manifestation of an underlying systemic infection. So we'll get to these things, but think about like rubella or measles or mumps. There's skin manifestations of an underlying systemic disease. A cutaneous hypersensitivity reaction, such as things like urticaria or hives, and then inflammatory skin disease. We'll talk a little bit about atopic dermatitis or eczema, things like psoriasis, and seborrheic dermatitis. So primary cutaneous infections, things that are very common that are definitely running around schools because they see me in my clinic, but they're also out there at the playground and in the grocery store. Impetigo or bullous impetigo, a bacterial skin infection. Tinea corporis, tinea capitis, this is the medical term for ringworm. Verruca vulgaris or warts, molluscum, and then pediculosis capitis or lice. Lice is kind of outside the scope of our presentation here because we could do a whole 45 minutes on that. But I will say pediatricians are excellent at treating lice, but most families are too, because you can buy really good effective therapy at the drugstore. And kids should not be removed from school for lice. But again, we can talk more about that offline if we need to. So impetigo or bullous impetigo, this is a highly contagious primary cutaneous bacterial skin infection. It's usually caused by the bacteria Staph aureus. Occasionally, it can be caused by group A strep. And when you have bullous impetigo, that means it's forming a blister clear fluid-filled like papule that is usually almost uniformly caused by Staph aureus. Bullous impetigo is more common in children and affects over 10% of them throughout their life course. And then what predisposes to this? Any minor scrape or trauma. So running and playing on the playground and scraping a knee. If you have eczema and you are scratching or any itchy skin condition and you have open wounds from scratching, but any underlying skin disease or open area of the skin can predispose to infection. And it begins with this like really little red vesicle with a clear fluid-filled papule transitioning to a pustule. And then they break down easily and you get these erosions with the honey-colored crust, which is the classic descriptor. And we'll go through some photos as well. And it can be anywhere, face, extremities. Patients are otherwise well. They don't have fever. They don't have systemic symptoms. Their lesions might be a little tender. They're often a little itchy, actually. But here's a classic example of the erythematous base with the honey-colored crust on the perioral area of like a preschool age child. And then around the nares, really common, especially after having a URI. Kids will blow their nose a lot and then pick at their nose because there's crustiness, and then they'll get a bacterial superinfection related to that. Here you can see the erythematous base and the honey-colored crusting. And then different examples, especially in patients with skin of color. In skin of color, you will not see erythema as red. It can look more violaceous or hyperpigmented. So you see the hyperpigmented patch with the crusting here, really large kind of exophytic erythematous plaque with the crusting here. Again, on that perioral location is a common area for bullous impetigo, the honey-colored crusting, scattered erythema, and superficial crusting and erosions. And this is the nape of the neck in a young man where instead of seeing that honey-colored crusting, it looks dark black-brown, and that's just because of the underlying skin tone of the patient. So when you have the bullous impetigo or the blistering impetigo, oh, sorry, this got cut off. It is a little pustule like this that immediately is very, very flaccid or very, very fragile. So with any lateral friction, it immediately denudes and it leaves this erythematous base. You can see this very, very large pustules. They don't tend to form as much honey-colored crusting. And when you have the bullous form or the blistering form of impetigo, it really does require oral antibiotic therapy to improve, whereas most other forms of impetigo will improve with topical antibiotic therapy. Example, if you see all the little ruptured vesicles and bulla with a little Colorado scale on the neck here. And then the nape of the neck, also, you can kind of see some of these flaccid, crusted bulla on the erythematous base. As I mentioned, in darker skin types, you don't see as much frank erythema. It's more purple or gray. This is a great example of honey-colored crusting on the erythematous base, and then some resolving more like heme crust on that erythematous base. So we want to use topical antibiotic cream or ointment. If it's widespread or not responding to topicals or the bullous variant, it does require oral antibiotic therapy. And usually children can return to school the day after, 24 hours after starting antimicrobial therapy, or if all of the areas are healed or crusted over and there's nothing moist or exudative, you can cover lesions with a bandage or clothing to prevent spread. It's just contact spread. And then at home, they need to wash hands, linens, clothes, all their affected areas that have come into contact with fomites at home to prevent superinfection or transmission. Molluscum. We see molluscum all the time. Molluscum is definitely not harmful, but it is sort of frustrating. And yes, it is contagious. But you're seeing pink to skin color, domed papules. This has central umbilication. This is a classic marker of molluscum. Not all of them have central umbilication. And this erythema looks a little angry, almost purulent, kind of almost like a little boil or pustule. This is a sign that a molluscum bump is going away. That is actually a clinical characteristic we call the BOTE sign, BOTE, beginning of the end. And it means the patient's host immune system is mounting an inflammatory response to get the molluscum to go away. So they tend to look a lot worse before they start to get better.
Can you share your screen again with us? For some reason, it popped off.
Oh, really?
Yeah, thank you.
Okay, it says you are screen sharing. Okay, so I'm gonna stop share and it will reshare.
Perfect. Okay.
Is that better?
Yep, we can see now. Thank you.
Okay. So molluscum is a cutaneous viral infection due to a pox virus, and it is spread via skin-to-skin contact and with fomites, and it's rapid and easy spread. Kids get it from siblings, from playmates, from locker room floors, gymnastics, swimming, wrestling, like close contact sweaty sports, essentially. And there's little pink domed skin-colored papules, often with central umbilication, which you can appreciate here. And then they're really common in skin folds just because of the friction and the moisture. So the axilla, the underwear region. And then, as I mentioned, that boat sign, the significant erythema and edema often kind of is the harbinger that it's actually getting better. So there we go. More examples, the little pink umbilicated papules here. On the buttock. So these Kebnerize, which is a phenomenon in which if the skin is injured, the lesions will develop within that area. So this child probably scratched their buttock and then the molluscum just popped up within that line. Some crusted molluscum with that erythematous border. You can see there's like pink-white inclusions. That's actually the viral body. And then scattered molluscum on the arm and the flank and several with that nice boat sign here. Solitary molluscum can be hard to diagnose because usually they come in clusters, but they can just be one. And then in skin of color, they will look a little more tan than pink. And you can get eczema. This is the popliteal fossils of the back of the knee. You can get eczema surrounding molluscum, and that is the body again kind of trying to fight it off, but it can make it really itchy. And you treat the eczematous rash like you would eczema otherwise, and you can treat the molluscum separately. We have many, many treatment options kind of outside the scope of this lecture, but they don't have to be treated. They all go away, but it can take months, sometimes years, 6, 12, 18, 24 months plus. They can be much harder to get to improve in an immunocompromised patient, but just because a kid has molluscum and a lot of them, even for years, it does not mean there's anything wrong with their immune system. So the vast majority are never treated, and we just give it a tincture of time. They can be treated with in-office and prescription therapies. And restrictions are no, there are no restrictions. Everyone, this is a childhood rite of passage. You can try and cover it with clothing when possible, but I do not want kids restricted from gymnastics or from swimming or from play dates or any other activity because of molluscum. Verruca or warts. A different common viral skin infection due to HPV, human papillomavirus. These are harmless, but they can be painful and quite stigmatizing when they're in highly visible areas. So frequently they're auto-inoculated. So a patient has one wart on their finger and they start chewing on it and then they get warts on their face. And Kebnerize, that phenomenon where there's injury to the skin and then you get warts in any area of injury. And prevalence is quite high in school-age children. I think most of us have dealt with even having a personal wart on a hand or a foot at some point in life. HPV is also transmitted via skin-to-skin contact or from warm, moist fomites, locker room floors, pool decks, showers. And then incubation is several months before lesions develop. The duration is highly variable. 2/3 resolve in about 2 years, but literature says that they can last up to 6 years or more sometimes. And they can happen anywhere on any epidermal or mucosal surface, anywhere on the skin, anywhere inside the nose, in the mouth, vaginal area, and distal tip of the penis too. This is like a gray scaly wart on the nose. And we call this one, this is called a filiform wart. It has these little projections. It's really common on the face, but all still warts. This is a ringwort. This was possibly treated with something that didn't treat it all the way to the edges, so it kind of pushed out the viral particles to the edge. Periungual warts, so warts around the fingernails can be quite painful because we use our fingers a lot, and then they can lift up the nail and make it more susceptible to trauma. So you're seeing a little hemorrhage just from normal trauma, and then this is the wart. And then this is a wart on the bottom of the foot that from trauma of walking on it, it's had little microhemorrhages into it, which is what is creating that brown, red, yellow hue. Again, a little wart on the distal nose there, a larger plaque type one on the hand. So the plantar warts, several clustered on the mouth, and more kind of skin colored to tan warts with an erythematous base on the dorsal hand. Flat warts can look like a lot of different things, mistaken for acne or other skin rashes, but they're very, very thin, skin colored to faintly hypopigmented, usually on the face. They tend to Kebnerize very easily, which you can see here probably from like a scratch on the forehead. They don't stick out nearly as much, but in skin of color, they can be really striking and look like other rashes that cause loss of color. This isn't a rash though, these are lesions. They're actually elevated even if they're minimally elevated. So as I mentioned, they spontaneously resolve, but recurrence is common. I should have mentioned, when you get molluscum as a child, you will eventually fight it off and you will not get molluscum again, barring exceptional cases in which older patients are profoundly immunosuppressed, so they're undergoing chemotherapy or they've had an organ transplant. But once you have molluscum, you're done with it. Verruca are not the same. You can get a wart, have it treated in childhood, and then you can have warts on and off throughout your life. And there's no lasting improvement or immunity for warts. Treatment is not necessary, but often families want it because of the stigma or discomfort associated with warts. Starting with an over-the-counter salicylic acid is very, very, very appropriate. They make over-the-counter, we're talking Compound W brand, Dr. Scholl's brand in the drugstore. They make also at-home freezing or cryotherapy. That is not effective and uniformly not recommended. We do cryotherapy in the office. That is different. It's much colder, it's painful, it's more effective. At home, they can use a salicylic acid 17 to 40% paint on solution, cream, stick, under occlusion with a Band-Aid or duct tape every single night. That's the most effective at-home therapy. In the office, we've got lots and lots of options. Tinea, ringworm. So Tinea corporis is ringworm of the body. This is superficial fungal infection of the skin due to a group of organisms called dermatophytes. It's transmitted through direct contact with people or animals, or sometimes fomites and the environment, dirt, grass, being at the playground at the park. Risk factors are excessive heat, high humidity, really tight-fitting clothing, because these organisms really like warm, damp, moist, warm, damp, and humid environments. And this includes Tinea faciei, so involvement of the face, Tinea pedis, which is athlete's foot, Tinea manum, which is the hands, Tinea cruris, which is of the groin or jock itch. This is often confused with many other things. And we lovingly joke that in dermatology, when something gets referred as tinea, we never think it's tinea. It's always going to be something else because everyone thinks everything is tinea. So by the time it gets to us, it's usually not, but sometimes it is. But not all ring-shaped things are ringworm or tinea. You can have nummular dermatitis or a nummular or round-shaped form of eczema, a less common skin condition called granuloma annulare. Numerous different ring-shaped rashes, psoriasis, pityriasis rosea, tinea versicolor, many things that can form little annular shapes or rings. So not everything that is ring-shaped is actually tinea, but classically it will be annular. So it'll have a nice, well-defined border with some central clearing. It'll be scaly or textured. It's often uniform, like there's there's one lesion. We'll show some examples where there's multiple, but it's not usually widespread like whole body. It's often itchy. Sometimes it's not. It'll be red or pink in lighter skin colors and violaceous or brown gray in darker skin types. And sometimes when it's been going on for a while, or if it's been treated inadvertently with a topical steroid, it'll develop pustules or like firm papules within it. And this is a fungus going down the hair follicle. And that is really common in lesions that have been around for many months, and almost uniformly common in hair-bearing areas. So the scalp and the face, like the beard area, the fungus gets down the hair follicle, and that has required different treatment. So really well demarcated, annular border, kind of see the elevated rim, central scaly center. Again, here some central clearing, numerous little discrete annular patches here. These is this the lightening in the center, like the central clearing, and this tiny papular nature at the periphery, and the single isolated, very well demarcated lesion on the shoulder of this patient here. Here you can see this is post-inflammatory hyperpigmentation from prior tinea that's been treated in skin of color. These are all these little papules at the edges. This is still active tinea, really active, beautiful, like inflammatory border of tinea. And then these little papules and pustules within this annular ring. Treatment is usually a topical antifungal cream or sometimes oral antifungal pills for 2 to 3 weeks. You encourage light, loose-fitting clothing. It takes weeks to see resolution of the symptoms, and there really aren't any restrictions for this. Once patients start treatment, they return to normal activity. Tinea capitis is ringworm of the scalp. So this is a fungal infection of the scalp hair. You have a non-inflammatory variant, which resolves without scarring, meaning they will not have permanent marks with hair loss. And then an inflammatory type, and that's like redness, pain, swelling, discharge, pustules, and that's more common to truly lead to permanent scarring hair loss. Tinea capitis is most common in preschool age to early adolescent kids, and you can get little patches of scaly spots and broken hairs with hair loss, and over time, more of the red papules and pustules, with the plaques increasing in size over time. Some different morphologies will be black dot tinea capitis. This is a classic, it's a classic hairless patch that you see little black dots. That's actually the hair follicles retained within the hair follicle. They just all broke off at the surface. So you still see the hairs in the hair follicle. That's the black dots. Carrion is a markedly inflamed form of tinea capitis where you get like this foggy, oozy, red, scaly crusted plaque. And then Favis is a really severe form of carrion where truly the scalp is encased in like these oozing nodules and abscesses and crusting, and is very uncommon in the United States. Treatment for tinea capitis. This is one thing that's important to recognize what this is and also some mimickers of it. But to treat any tinea capitis or tinea on a hair-bearing area, you need oral treatment. You can't do it with the cream because it goes down the hair follicle. Household members should be screened. Infected children should be isolated within reason until treatment has started, but really just avoiding sharing personal care items like hats and brushes and combs. And then hair equipment should be cleaned or disinfected or replaced, meaning like their combs and brushes at home. If it can be disinfected, great. And if it can't be, it should be thrown out and replaced. So examples here, like pretty discrete areas of hair loss or alopecia and those black dots, scaling erythematous annular border, discrete scale crust. This here is not like classic tinea capitis. This is very, very classic, but this could be tinea capitis. This could be seborrheic dermatitis. This could be atopic dermatitis or psoriasis. So not all scalp scaling rashes are tinea, but it is worthwhile to make sure if a child has one single discrete lesion and it's becoming more inflamed or pustular, they need to be expediently evaluated because the earlier we treat, the better it improves. If we wait too long, it can lead to scarring. This is that black dot where you see broken off hairs. This is just diffuse, like fine white scale. This looks like dandruff, seborrheic dermatitis. And that's why it's important that these patients often have fungal cultures, scrapings done when they're in the office. And again, a very large, broad area of the black dot tinea capitis. So an example of the more inflammatory subtypes like carrion, you see like the crusting, scale, ooze. Not a lot of other primary scalp conditions do this. So atopic derm, psoriasis, sebderm uncommonly create like a discrete, boggy, indurated plaque. This is very, very well demarcated with the erythema and scale. And this is almost bordering on FAVIS, where you're seeing these like crusted, yellow, adherent plaques throughout the entire scalp. So we're going to move on to the inflammatory skin disease, which a lot of this can overlap with what we are just talking about with tinea and tinea capitis. So inflammatory skin disease are things like atopic dermatitis or eczema, psoriasis, alopecia areata, and seborrheic dermatitis. Atopic dermatitis is incredibly common. It affects up to 20% of children, and it is a chronic disease with intermittent exacerbations and remissions. We have to treat it in a multifaceted way to actually get improvement. So we have to target itch on the skin, inflammation, which are their red scaly plaques. We have to prevent them from getting infection. And effective treatment really requires diligent time on part of the provider, the parent, and the patient, because usually it's not a patient doing their skincare treatment, it's a parent or caregiver doing it for them. So eczema, very itchy inflammatory skin disease. It's often in school-age kids on flexural surfaces. So antecubital fossa, popliteal fossa can be very erythematous, very eroded, painful, oozy, itchy, and they can develop bacterial and viral superinfection inside of those actively inflamed areas. You don't have specific precautions for a child's skin, but it's important to know that this is something that can be sensitive to temperature and weather changes. A lot of kids flare in the winter when it's cold and dry, but a good chunk of kids don't do well in the summer when they're hot and there's more humidity and they're sweating more. Itch of their skin can be highly distracting, and it's one of the reasons we may escalate therapy is because a child is so distressed by their itch, even if their skin disease isn't that severe. It goes along with things like asthma and environmental and food allergies. And treatments include a whole host of different things, but at baseline, frequent bathing and liberal bland emollients, so thick white creams and Vaseline, topical steroids and steroid sparing prescriptions, oral antihistamines, light therapy, which is a treatment we do in the office, and kids have to come in 2 or 3 times a week. And then we have oral and injectable medications that are prescription. There's many of them. They're highly varied. They can be very, very, very effective in the kids that need them. But secondary infection is something we worry about when they have eczema on the face. You can imagine this is at high risk for impetigo. So you're seeing some of that honey-colored crusting here. They can also develop eczema herpeticum. So this is a herpes simplex virus or HSV infection on top of atopic dermatitis, and that can be severe and widespread. In patients with skin of color, you may not see as much erythema, but what you're seeing is hyperpigmentation, violaceous discoloration, and the superficial fine white scale. These are both examples of pretty severe and chronic atopic dermatitis. very widespread erythematous eroded plaques. We call this lichenification, when the skin gets hyperpigmented, thickened, and you see increased skin markings, and it's a sign of severe and chronic disease. Very eroded plaques in the popliteal fossa. This is the scalp of a patient, which hard to tell from, is this psoriasis, is this seborrheic dermatitis, but erythematous, scaly, crusted plaques, intensely itchy, and can be associated with diffuse hair loss, but usually not discrete patches of hair loss. And then this is when it's not just eczema. So we were talking about things that can complicate eczema. Here we see some of this honey-colored crusting, but the most important thing here, this child has two very well demarcated, kind of like punched out erosions. This is eczema herpeticum. So this child has an HSV, usually HSV-1 superinfection that can be very severe and very widespread, and they need to be started on antiviral therapy immediately, usually with antibacterial therapy as well. And if it's around the eyes or diffuse on the body, these children usually do have to be admitted because they can become very seriously ill, and there can be complications of even like encephalitis, meningitis, pneumonitis with eczema herpeticum. If it's caught at early stages, we can keep them out of the hospital, but it can turn bad very quickly, especially in someone with poorly controlled atopic dermatitis. We often give antibiotics at the same time because they have so many open areas on their skin. They're very high risk for bacterial superinfection too. Okay, psoriasis, another chronic inflammatory skin disease. Psoriasis is characterized by usually very discrete, obvious, well-demarcated erythematous plaques with a white or silver, we call it micaceous, which is like oyster type scale. It can affect any part of the body, but it has certain areas it likes: scalp, behind the ears, belly button, elbows, knees. And then in some patients, they have what we call inverse psoriasis. So it affects the fold areas instead of the external areas. So the axilla and the groin areas. Psoriasis can be associated with psoriatic arthritis in up to about 25 to 30% of patients. And so persistent joint pain, especially worse in the morning, associated with swelling or redness of a joint, is something we will always evaluate for in a patient that we're seeing with concern for psoriasis. So you can see, contrast to atopic dermatitis, atopic derm tends to be really poorly defined erythematous plaques. Psoriasis is really like you could take a marker and specifically draw around it. This is the thick white silvery micaceous scale, which not all psoriasis lesions have at the beginning. And then patients with skin of color, again, it's not going to look as red, it'll look a little bit more purple. And this is pretty severe scalp psoriasis, also involving the external auditory canal and diffuse yellow, white, flaky scale, diffuse yellow, white, flaky scale. The vast majority of like diffuse yellow, white, flaky scale on the scalp in a school-age child is probably not going to be tinea capitis. It's probably going to be inflammatory skin disease like psoriasis or seborrheic dermatitis. But of course, we can easily do a scraping for tinea and make sure it's not something simple that we can treat and cure, because psoriasis and subderm are chronic inflammatory skin diseases that require ongoing treatment. So if there's any concern in our offices at all, we will be doing like a scraping for fungal culture. But most kids that have like severe entire scalp involvement for years on end, it's not related to tinea. Topical, so treatments are very numerous for psoriasis. Topical creams and ointments, again, light therapy in the office, many orals and many injectables. But it is a chronic disease with exacerbations and remissions, and it can specifically be triggered by a group A strep pharyngitis or like cutaneous infection. Kids can get a form of psoriasis called guttate psoriasis, which means raindrop. So little tiny psoriasis patches that pop up all over in a few weeks after a strep infection. And that initially doesn't look like those large, thick psoriatic lesions because they're so small, but important to recognize that that's one of the most common type that happens in school-age kids. Okay, seborrheic dermatitis. This is the fancy medical term for dandruff, inflammatory dandruff. It's the same thing as cradle cap, and then it transitions into kind of dandruff in older kids and teens. And it affects skin that's really rich in oil glands, sebaceous glands. So the scalp, the nasolabial folds, the eyebrows, the ears, the chest, and sometimes the fold areas like the axilla and the groin. It does peak in infancy and again in adolescence and early adulthood. Malassezia is a normal commensal yeast in all of our skin flora. But in seborrheic dermatitis, there tends to be the skewing of the normal milieu, and it can cause an inflammatory reaction that makes things more red, more scaly, more textured. There's also an overlap of seborrheic dermatitis and psoriasis of the scalp and the ears and the face, and we call this sebopsoriasis. What you're appreciating here, this patient has a darker skin type, but this really well demarcated rim of erythema that goes throughout her entire scalp with maybe some minimal or fine flaking or scaling. This is the scalp with background like it's that really orangey pink. It's not super thick, and then lots of yellow, white, greasy scale. Here you're seeing the eyebrows involved, fine pinky orange patches with superficial yellow scale throughout. And then this is a patient with skin of color whose subderm has been treated, but it left significant post-inflammatory hypopigmentation. So essentially the skin was so inflamed, it kind of turned off its ability to make color. And so you get these discretely hypopigmented areas after treatment. They will improve over months with really diligent sun protection. So SPF like 30 to 50. It can be really itchy, seborrheic dermatitis, and treatments are medicated shampoos such as Selsun Blue, Head and Shoulders, prescription ketoconazole, and then we use topical steroid solutions, creams, lotions, and shampoos, and there are a couple non-steroidals available. Usually it's going to be an ongoing treatment, but we can make it drastically better and very maintainable. Alopecia areata. So alopecia is a cutaneous autoimmune disease that causes non-scarring patches of hair loss anywhere on the body, most frequently the scalp, but it can be eyebrows, eyelashes, and body hair too. There is no redness or scale. It is not itchy. It is not painful. And sometimes it happens very suddenly, where a patient wakes up overnight and they have patches of hair loss. It's highly unpredictable. It can come and go. It can fully remit. It can progress to complete hair loss. Treatments may work. Treatments may not work. It is very, very unpredictable and sometimes very challenging to treat. And that's hard as a patient and as a provider. Examples, this is pretty diffuse non-scarring hair loss, involvement of the eyebrow, the scalp, retroauricular scalp here. But you can see there's no redness, there's no scale, there's no flaking. There should not be any of that for alopecia areata. So these kids have no restrictions. They may need some specific nuances of psychosocial support because bullying can be really, really intense, and this can be very, very stigmatizing skin condition, especially for our older school age and early adolescents, and especially for young women. Not saying that young men don't struggle with this, but young women tend to struggle a little bit more just because of the social complexities of not having hair as a young woman. We treat with topical creams and ointments, oral medications, injections, many, many, many different things. And the treatment algorithm kind of advances depending on how severe their disease is and if they're responding to treatment or not. Oh, this got put out of order. We already talked about psoriasis. Cutaneous manifestations of systemic infections. Okay, so these are systemic illnesses, you are sick, that have a primary cutaneous eruption. So think of chickenpox, shingles, measles, mumps, rubella, hand, foot, and mouth disease, things like this. Chickenpox or varicella is an acute, highly contagious exanthem. It is due to a primary infection with varicella zoster virus, and it's spread via respiratory droplets and also from the skin vesicles to the respiratory tract of susceptible kids. Incubates for a few weeks, the eruption lasts a few days, and usually resolves without complication in most. These are examples of, it's called a dewdrop on a rose petal. So you see a little vesicle on an erythematous base, and they're in various stages of healing, can be intensely itchy. This is a really severe fulminant widespread case. In skin of color, it's going to look less red and more violaceous. And here you can see these clustered vesicles on the legs of this child. And on the face here, multiple different vesicles and different stages of healing, and these little erythematous vesicles on that erythematous background. So usually they're going to have fever, malaise, and then rapidly progressive vesiculopustular eruption with the crops of little macules and pustules progressing over 12 to 48 hours, and crops pop up over a few days before crusting over. Varicella vaccination is generally now routine, so it's less commonly seen, but in those who are vaccinated, you can still get breakthrough varicella. So you've been fully vaccinated, but you are exposed. You have a milder variant of the illness. But don't forget that varicella vaccination is happening not in infants. And so based on the timing of the immunization schedule, 12 to 18 months, and then again, a repeat booster at 4 to 6 years. So young infants are susceptible to this. You're contagious from 2 days before the rash appears until all the vesicles are crusted. Usually we just treat with supportive care, and rarely is antiviral therapy needed for severe varicella or those with comorbidities such as frank immunosuppression. So these kids, from the time they're feeling unwell, fever, rash, should be staying home and isolating, and can come back to school essentially when all the vesicles are crusted, assuming all their systemic symptoms have improved too, especially no fever. Shingles is herpes zoster, varicella zoster, herpes zoster virus. This is reactivation of latent infection with varicella zoster virus. It's much less contagious than primary varicella. It's uncommon in kids, and that's because usually you have to have varicella, and then that virus becomes latent in your nerve roots, and it has to reactivate over time. So kids usually don't have enough time in their life to get it, harbor it, and then reactivate it. However, if mom had varicella during pregnancy, if the child had varicella in their first year of life, or they're immunocompromised, they're at higher risk for getting shingles. And interestingly, in adults, we think about this as being one of the most painful skin eruptions that can happen. Kids often don't have the same prodrome of the burning pain and tingling in the affected dermatome, which adults have. So just because it's not horribly painful does not mean it's not shingles or herpes zoster. But it's very grouped or confluent vesicles on an erythematous base, usually in like these striped bands on the skin, which is your dermatome. They crust and resolve over a week or two. They can be painful or itchy. Usually we treat with supportive care. You can consider antiviral therapy if it's diagnosed within the first like 24 to 36 hours. But similar looking to varicella, like the vesicles on the erythematous base, but in very, very well demarcated areas. When this is on the face, this can signal involvement of the cornea. And so especially if it's on the forehead or the nasal tip, that child needs to urgently see a provider. They have to urgently actually get in with ophthalmology to determine if there's any corneal involvement. But little vesicles in this very well demarcated striped band, and then they get this like heme crusting over time. So VZV versus HZV transmission. So an individual with chickenpox, varicella zoster virus, can transmit chickenpox to someone that is susceptible. An individual with shingles, which is herpes zoster, can transmit chickenpox to someone that's susceptible. You don't give shingles, someone doesn't catch shingles from someone else because shingles is your body's reactivation. So someone with shingles cannot give shingles to another person. They can only give them chickenpox if they are susceptible. Measles or rubeola, something that I have not seen before, but in our current climate, maybe we'll be seeing at some point, hopefully not. This is highly contagious virus. Most children in industrialized countries have been vaccinated, but we have mounting increases in rates in the past 5 years in the US, transmitted via respiratory droplet, and it can remain viable for up to 2 hours in the general airspace after an infected person leaves an area. And that's why measles can run rampant, especially in closed settings like prisons, dormitories, schools. It enters the upper respiratory tract, it incubates for 1 to 3 weeks, and then you get the rash a couple weeks after exposure. And you're considered contagious from 4 days prior to the rash through 4 days after. You get this prodrome of fever, chorizia, which is nasal congestion, cough, and conjunctivitis. And then this onset of rash, which is called morbilliform, which really just means measles-like. So thin erythematous papules from the head down to the toes. Now, measles was declared eliminated in the US around 2000, but we still have outbreaks, and most are associated with the import of measles from unvaccinated travelers. But then it comes to the US and we get outbreaks in communities that have low overall general community vaccination rates. You get oral lesions, little white gray spots in the mouth, and then the erythematous macules and papules starting forehead and behind the ears, and they go down and spread to the trunk. The rash peaks for a few days and then fades. Rash not dangerous, but it is a sign of the underlying skin disease. These are the coptic spots inside the mouth. You can get little petechial hemorrhaging too. Difficult to see in this photo, didn't project well, but little white gray coptic spots. And examples of measles, the erythematous, they can be tiny, they can be a little more papular, but fine erythematous pink papules from head to toe. It's not really a specific rash for measles. A lot of rashes look like measles, but in the appropriate clinical context, this is where the term comes from. Okay, mumps, which is another viral infection that can have cutaneous manifestations. This is virus spread via direct contact with respiratory secretions and saliva. It incubates for a couple weeks, and then you get fever, headache, malaise. Parotitis, which is parotid gland inflammation, is much more common with mumps than other viral infections. It peaks within the first few days, then resolves. And rates in the US have declined since the 1960s when vaccination was introduced. And then really commonly you get posterior cervical lymphadenopathy, which is what this photo is showing, specifically with mumps. The parotid swelling is this lateral facial swelling here between the earlobe and the angle of the mandible, this getting really full. Rubella or German measles, transmission via respiratory route, incubates for a few weeks. They get standard flu-like illness symptoms, and the rash starts on the face and spreads distally and disappears over a few days. An infection in the US is pretty rare due to routine vaccination, but you can tell like this rash, you can't really completely distinguish it from the measles rash. Standard measles, you cannot. These are all measles type appearing rash. In dermatology, we use the term morbilliform. Morbilliform means measles-like, but it describes the viral eruption of many, many, many different things. So I won't belabor this, but we do have, these are vaccine preventable diseases. The trivalent measles, mumps, rubella vaccine plus varicella vaccine is administered in 2 doses, with the first receiving around 12 months of age and the second dose between 4 and 6 years. Estimates of the effectiveness of the vaccine are 99% in measles prevention after the second vaccination, and over 95% of prevention of mumps and 90% for rubella. Varicella vaccine is 70 to 90% effective in preventing varicella and more than 95% effective at preventing severe varicella. Okay, moving on to herpes simplex virus. This is cold sore virus, herpes HSV 1 and 2. Cold sores are very common worldwide. They usually affect the oral, labial, and sometimes genital regions. They're highly contagious, spread by direct contact with virus-containing lesions, saliva, or other body fluids during viral shedding. The virus establishes lifelong latency in your dorsal root ganglia. So once you have a cold sore, you're always at risk for getting more. And then disease occurs with reactivation, and that can be spontaneous, but usually can be with trauma, UV exposure, so sun, fever, or immunosuppression. Primary herpetic gingival stomatitis, the first time a child gets HSV, is much more common in childhood and much more severe symptoms, kind of like clustered all around the oral labial mucosa and inside the mouth. Can be very, very painful, cause a lot of swelling, and have systemic symptoms. The episode resolves over a couple weeks. Viral shedding can remain for a few weeks. This is just supportive care. So controlling fever if it's there, making sure the child stays hydrated, lips stay really moisturized with like Vaseline. So as long as they are afebrile, drinking, tolerating PO, and all the lesions have crusted, they can absolutely return to the school environment. It is a recurrent disease. There can be a prodrome of itching, burning, or pain, and then you get these little vesicles on an erythematous base. The lesions are contagious until they're totally crust over. If we're going to do oral antiviral therapy, it's only helpful if it started honestly within 24 hours of onset of symptoms. So if a patient has been seeing me and I know they get recurrent oral labial or otherwise cutaneous HSV, they will have an at-home prescription to start when their symptoms start. Otherwise, by the time they encounter a healthcare provider, it's usually been too late to make a big difference. But you can keep the exposed areas covered. You can do frequent hand washing. As long as the area is covered from like contact to other people, safe for them to be at school and even to play sports. Enteroviral exanthems. So this is hand, foot, and mouth. We have typical and atypical hand, foot, and mouth. Typical hand, foot, and mouth just means the typical clinical appearance. They have fever, they don't feel well, they get little gray-white vesicles on the palms and soles, and they get vesicles and erosions inside the mouth, maybe with some lymphadenopathy. It's caused by Coxsackie virus A or B and enterovirus 71. Atypical Coxsackie is where their skin lesions predominate in a different way. They're more edematous papules, and they're on the extremities, more in the palms and soles and perioral area, less actually involvement of the oral mucosa. So this is classic hand, foot, and mouth, football-shaped gray-white vesicles on the hands and the feet, and these little kind of gray purpuric lesions on the knees here. This is atypical hand, foot, and mouth, so much more edematous papules, and they're clustered on the extensor extremities. This is on the face, where you're seeing more perioral and not intraoral involvement. And you can see like almost like some petechial macules on the hands. And then 6 weeks after having hand, foot, and mouth, they can shed all of their nails. That's called onychomadesis. Different viruses can do it, but hand, foot, and mouth is really, really classic to trigger that, which can be quite alarming, but it's totally reassuring. They will painlessly shed and regrow. Atypical hand, foot, and mouth can cause a lot more like hemorrhagic and bullous crusted areas and much more extremity involvement, buttocks and groin involvement than classic hand, foot, and mouth. Here you see buttocks, perioral, palms and soles affected, extremities, and the torso is often spared in these cases of hand, foot, and mouth. So Coxsackie virus infection also will cause something called eczema coxsackium. We talked about eczema herpeticum, where you get herpes virus infection inside of atopic dermatitis or other underlying skin disease. Coxsackie can also cause an accentuation in patients with atopic dermatitis, where they get much more severe flaring of their underlying skin disease and of the Coxsackie virus exanthem within their previously involved areas. So for example, like these are eczema coxsackium. So they get much more erythema, crusting, irritation in their previous areas of eczema. This we just treat with supportive care and treating the eczema. And you want to make sure it doesn't get that honey colored crusting because that does need bacterial, antibacterial therapy. Pityriasis rosea. So this is a very common self-limiting rash that often starts what we call a herald patch. So it's a larger, kind of like pink, orangey, thin plaque or patch with a little collar red of scale. It's usually on the trunk or extremities. A couple weeks later, they will get all of a sudden a bunch of tiny little similar patches in this Christmas tree distribution pattern on the back or the chest. They can have some mild URI, flu-like symptoms, but the etiology is linked to exposure to human herpes virus 6 or 7. And in patients with skin of color, these lesions can be a little more bumped up and papular. In fairer skin patients, they tend to be really flat and pink or orange. So herald patch, herald patch, herald patch. Can't see the herald patch here. And then all these small, almost looking like psoriasis or guttate psoriasis, thin scaly plaques, they pop up. They're pretty asymptomatic. They can sometimes look a little round or annular with that fine white scale and that pink background. And it resolves over usually 4, 5, 6, 7, 8, 9 weeks. You can use a topical steroid on it if it's itchy. It's usually not, but nothing else will make it get better faster. So it really is just a tincture of time. The rash itself is not contagious. This is just a manifestation that they were exposed to a common childhood illness, which is HHV 6 or 7. Okay, I want to be mindful of time. We have like 3 more minutes.
There is just one question that I see in the chat right now with regard to what the best treatment is for warts. So I don't know if you have more
Okay.
slides you want to finish and then answer
Yeah,
that
I'll
one
do a few
quickly.
more. I know we wanted to leave at least 10 minutes for Q&A, but let me do at least a few more. So cutaneous hypersensitivity reaction. So what this means is it's secondary skin manifestations due to some underlying disease process, but the skin manifestation isn't infectious at all. It's just an underlying immune activation. So it's usually an infection that causes it. So this is going to be urticaria or hives, a variant of hives called urticaria multiforme, and then like a vesicular pustular eruption called erythema multiforme. So hives, these are wheals, pink swollen patches that are really itchy, and then you get swelling of the subcutaneous tissue called angioedema. They can be acute or chronic. The most common cause in kids is a viral URI, or that they've been exposed to something they're fighting off. It can be due to a food allergy or medications, but by far and away it's viral illnesses. An individual lesion lasts less than 24 hours, but overall episodes of hives can last much longer. So pink, smooth, edematous, itchy patches. These are not scaly, they're not textured, and they migrate around really quickly, and they can be really, really diffuse and widespread in some kids. If there's concern for airway involvement, facial edema, respiratory distress, of course, we're talking 911 and emergence IM or subQ epinephrine. But without concerning signs or symptoms, you can do antihistamines like cetirizine, hydroxyzine, Benadryl, and it will help improve the itching. It may even help clear up the hives, but really they will run their own course. This is a type of urticaria multiforme. So this little one has some congestion, a runny nose, a single low-grade fever, and what looks like a really striking rash. You see these like annular and targetoid patches, erythematous pink edematous patches. This is a form of urticaria called urticaria multiforme. So it has like nice little annular rings. It can be kind of purpley in the center. It's benign, it's self-limited. It happens a few days after a viral illness. It does move around. It responds to antihistamines. No need for intense workup, no need for other medications, but just antihistamines to control pruritus, and it will resolve on its own. More examples of this nice like annular borders, polycyclic lesions, some dusky violaceous centers. As long as they're moving around and the kid otherwise looks pretty well, even if the rash looks striking, very consistent with urticaria multiforme. You can see on the cheeks and the chest of this little one, annular and polycyclic on the back and trunk there. They can get a good amount of edema, especially at the dorsal hands and feet. And then lastly, erythema multiforme. This is different because this is a hypersensitivity reaction of skin and mucous membranes. They often get these classic Target lesions, like think about the store Target. So you're seeing the central darkening, pallor, and a darker rim. This is more common in our older school age and early adolescent kids. The most common trigger for this is going to be a primary HSV infection, not primary, but they're having an HSV reactivation or infection that will trigger erythema multiforme. It can be all over the body, but palms and soles are common. And then getting some oral mucosal erosions is very common, but it really should be limited to like just the mouth. They could have some ocular involvement or some genital involvement as well. They can have a little bit of a low-grade fever. We treat with supportive care. Very uncommonly is this severe or recurrent, and we have to take other action. But these lesions are fixed. They pop up and they last for days or weeks. This should be evaluated by a provider just to make sure we're not heading in the wrong direction of a more severe eruption. But if they feel well, and there's no fever, there are no restrictions, and these lesions will resolve without scarring over a period of weeks. Okay. I think I'll stop there. I could do one more diagnosis, or I can just stop here.
I just see one other question, unless there are some other questions. So the first question was, so let's do this, maybe answer these two questions, and then if
Let
we
me do
have
that.
no more questions, maybe go on to another one.
Okay.
So Sarah wanted to know what the most effective treatment slash therapy is for warts.
There's not just one. Multifactorial therapy will be the most effective. So in office, we can do cryotherapy or freezing. We can do intralesional candida antigen injections in conjunction with at-home topical salicylic acid. We like a prescription, higher strength compounded salicylic acid that's a combination of salicylic acid and 5-fluorouracil, which is like a topical chemotherapy agent. It is really irritating, but it's much, much more effective. So it's usually the combination of doing multiple things will help get them better faster.
Awesome, thank you. And then Leanne's question is, how do you recommend to differentiate pityriasis versus ringworm? Because they can look similar. So do you need a doctor diagnosis for correct identification and treatment?
So with ringworm, I know I showed a couple different pictures or examples. With ringworm, you usually have fewer lesions. It's usually one, maybe two, and it's not starting with that one patch and then all of a sudden over a few weeks, you just get a whole bunch more. So that characteristic one patch and then a bunch of new ones that are kind of all trickling around on that location, like mostly the upper back and chest, the trunk predominates, is much more characteristic for pityriasis rosea. PR also is going to be a little bit more common in older kids and adolescents. Tinea is more common in younger school age kids, but you're thinking of more one or two lesions and not just on the trunk. They can be anywhere on the body. They do tend to be itchy and tend to be very, very well demarcated, like sharp borders. And the pityriasis rosea can be a little less well defined. I would say you do not need a physician to provide the diagnostic clearance unless it's highly symptomatic for the patient, like super itchy or uncomfortable, because then if it is tinea, we just need to treat it to get on topical therapy. But if it's otherwise asymptomatic, I would give it several weeks because PR will go away. If it's tinea and it's not treated, it'll likely persist around.
Awesome, thank you. If there are any other questions from the attendees, if you want to come off mute and ask directly, otherwise feel free to put them in the chat. Lisa just said, I see many odd in quotation rashes. It's hard because the teacher is often alarmed. Usually there's no fever, but if it's not localized, I call the parents and recommend that they be seen by their primary care. Is this reasonable?
Yes, I mean, I think it's challenging if it's an acute onset of new rash that is whole body widespread. It's reasonable that they're evaluated by primary care. I know, so my daughter gets hives randomly, like all the time, and I get calls all the time, and they will usually describe to me what's going on. I'm like, okay, if she is not having respiratory symptoms, she's just going to stay at school and it's going to be okay. That's different. I am a physician, right? And I'm a dermatologist. But if it's a new widespread skin eruption, I think very reasonable to say they need to be evaluated. If it's chronic and ongoing, I wouldn't say they should be like pulled from class that day or like an intervention in that moment, but more of like a discussion of like, is this something they're being seen for so that we know so that we can stop worrying about it?
Great. And then one more question from Leanne. She was curious if you would have any contact precautions for a weight room if there is a student who is diagnosed with ringworm.
Once they're on treatment, no. And if they can keep the area covered, no.
Okay, I say we have 5 more minutes. Do you want to cover a little bit more content?
Okay, I'll do one more topic because this comes up frequently and we're about to hit a time of year where it's really common. So think about a 6-year-old, this could be an 8-year-old, a 10-year-old, probably elementary school mostly. Recurrent pink bumps on the arms and the lower legs. They're itchy, they go away, they come back. No one else in the family has a similar eruption. There's no pets at home. These little pink firm edematous papules on the dorsal hands. That's about what this could be. I mean, anything, right? You're like, I don't know. Is it one of those molluscum things? Like, how long has it been going on? Like, are you scratching? Are you getting bit by something? Could be hives, could be molluscum. Is it a viral rash? So this is something called papular urticaria. This is a chronic recurrent eruption due to a hypersensitivity to a bite. I cannot tell you which bite. Families really, really want you to look at a bite and know what bit them. I wish I could do that. That would be really cool. I cannot tell you. I can just usually tell you that they're being bit by something, but it can happen from a mosquito, a flea, a bed bug, a carpet mite, a dust bite. But little pink edematous clustered papules, they can be like crusted from being scratched and excoriated. A flea bite is the most common cause of this, but an individual lesion will resolve over a couple weeks, and then it heals with a little post-inflammatory erythema or hyperpigmentation. It gets better, but they keep getting recurrent episodes very commonly in the same location. But anytime they get bit by anything, all these like previous areas will start to highlight again. And it's very frustrating for families to be like, I've cleaned my house from top to bottom and nothing is biting them. It has nothing to do with cleanliness. It is their skin, their kids' like overactive immune system reacting to any sort of insect bite, and they do just improve over time and it stops happening. And treatment is really oral antihistamines, topical steroids, antipyretic lotions, and then insect repellents and protective clothing when they go out, especially when I mentioned like seasonal transitions. This is a spring and late summer thing. We start going out, the kids are playing in the grass until dusk, and they're getting bit by little things, and it's causing them to get this like recurrent papular eruption. So doesn't need to be concerning. Yes, it can just happen to one kid in the family, and you just control the symptoms and it goes away. And that is the end of the presentation.
Thank you so much. That was so great. Everybody have a great rest of your March, and we will see you in April.